All right, Dr. Das, thank you so much for joining us, and thank you for the audience. We also have our medical residents in Bingo Baptist Hospital in Cameroon. I think Dr. Das, you might be able to see them. They have been with us for more than 3 years, and we also have physicians from different countries who have joined us today. So thank you so much, everyone, for joining us, and I apologize for the delay. All right, Dr. Das, let me start with the introduction, and then you can start presentation. Thank you again. Hello, everyone, and welcome to Health for the World International Grand Rounds. We are honored to have our Grand Round speaker today. Our Grand Round speaker is Dr. Devika Das. Dr. Das is the Clinical Assistant Professor of Hematology and Oncology at University of Alabama at Regimen. She has had multiple achievements, including Glenn Globes and Edwin Rutsky Award for Clinical Excellence from UAB Department of Medicine in 2019, and also an Outstanding Teacher Award from UAB Division of Hematology and Oncology Fellowship in 2018-2019. She also got a UAB Medicine Teaching Excellence Award in 2017 and 2018. And Dr. Das, we're really honored to have you. And Dr. Das's topic today is metastatic non-small cell lung cancer, a primer.
Good morning, everybody. Thank you so much for having me here. Can y'all hear me okay?
Yes, we can hear you okay.
Okay, perfect. All right, so I am going to talk about a topic that is something that has grown tremendously in the past 3 to 5 years, and is not something that I can cover in entirety in one lecture, but I will try to do a primer and just a broad overview of how much progress we have made in this field of non-small cell lung cancer, which historically was considered a devastating disease, which it still is, and was fatal for most patients who had metastatic disease, would die in 6 months. And now we have made so much progress that we're able to provide not just quantity of life, but also good quality of life for our patients. Feel free to stop me at any point with questions. I'll keep this short so we have some time for discussion in the end. I have no conflicts or disclosures to make today. So what do I specialize in? I am passionate about lung cancer, but I'm also equally passionate about process improvement and providing high value, high quality care to our patients. That, in combination with participating in medical education and the fellowship program, what I consider my niche is sort of combining the three and coming up with the best way to train the next generation of oncologists and providing the best care to our patients with lung cancer. So what will we discuss today? I want to start off a little bit with talking about the diagnostic process for non-small cell lung cancer, especially in the metastatic setting. We'll then kind of move on and look at a very broad category of mutation-driven metastatic non-small cell lung cancer, then touch a little bit about the non-mutation-driven metastatic non-small cell lung cancer. And finally, I want to end with talking a little bit about immune-related adverse events, which is something that we will be seeing a lot more in our patients, especially our patients with lung cancer, where immunotherapy is becoming sort of a frontline treatment for a lot of our patients. And it just opens up a whole new set of side effects that a lot of us need to be thinking about. So really, this is going to be a 30,000 feet view. So I apologize in advance that we're not going into every little aspect of non-small cell lung cancer, but hopefully just enough so everyone knows what to go look for and feel a little bit more comfortable taking care of these patients. So let me start off by this. There is no such entity as non-small cell lung cancer. Historically, anytime we did a lung biopsy, we would get a result that would say it is either a small cell lung cancer or a non-small cell lung cancer, and everybody would get chemotherapy. Well, that is not the case anymore. We have made so many advances in this disease. So historically, it was one entity. Everybody got chemotherapy. Then we began to understand that there are some patients that on histology have adenocarcinoma. Some patients have a squamous histology, and then there is this whole other bucket of diseases, the large cell neuroendocrine tumors, and certain that did not fall into the other neat buckets. But what we're learning now is even within the adenocarcinoma subset, if you were to look and do genomics on these tumors, there is so much heterogeneity, and there are so many different driver mutations that might be driving the growth of this malignancy, and they are all treated differently, they are all behaving differently, and they just mean different things in terms of how we approach patients with non-small cell lung cancer. So I think the one takeaway point from this, if there's just one thing you had to learn from today, would be that don't be happy with just a diagnosis of non-small cell lung cancer. We really should be striving to find out more about that tumor, because it makes a difference in how we treat the patient. So let's go a little bit into the diagnostic process of non-small cell lung cancer. The way I see it is it's a team sport. It takes multiple different doctors and nurses and procedures and just a whole team of people who take a patient who has a suspicious lung mass that is concerning for cancer and taking it all the way to the point of them getting the diagnosis of whatever the cancer they have and getting them started on the optimal treatment. It's something that we don't think about a lot. How long does it take? Just think about your institution, just think about where you practice. If today you or your loved one were to have a chest CT or an X-ray where you found a lung mass, how long would it take for that person to go through all the different staging, biopsies, waiting for path report? How long would it take for them to go from there to actually getting a diagnosis and starting that first treatment? May that be surgery, radiation, or chemotherapy. And that's important because there is not a lot of data on it, but small different groups have looked at studies, and sometimes it can average as much as 133 days or months before some of these patients. And it's really a lot of this is care coordination, is getting the right things done in a timely manner so your patient can start treatment in an appropriate time frame. And that's very important. And so some of these some of the experts would recommend that we should really try to get this done within a month, which seems reasonable, but is really hard, especially if you are a resource poor practice. So some pearls in biopsy. When you suspect somebody has advanced or metastatic non-small cell lung cancer, it's okay to biopsy the primary tumor or any easily accessible metastatic site. I would caution against doing a bone biopsy, because it might give you a diagnosis, but once you decalcify the bone, it is very hard to run next-gen sequencing on that sample. So you have a hard time getting all of these mutational drivers that you're trying to look for. In places where it's available, or if you don't have access to tissue, again, this might not be cost-effective for everyone. There is an option to do liquid biopsy, or cell-free DNA in plasma, and that can give you a lot of information. If it's positive for a driver mutation, then that's great. But if it's negative, that doesn't mean the patient might not have a driver mutation, and that's important, and it's something that we need to keep in the back of our mind. The next thing I want to address a little bit is the stigma associated with lung cancer. So historically, there has been a lot of stigma with lung cancer. It's always something that was considered as a disease of the smokers, which is fine. But anybody with lungs can get lung cancer. I know from personal experience, there are patients who would not want to talk about their diagnosis because they instantly feel judged because of how the lung cancer is just always associated with smoking, which is not always the case. Anybody can get lung cancer. And we just need to be able to talk about it equitably and talk about it openly, and everyone deserves the best care that's available. So we need more research, we need more funding, and we just need more resources for lung cancer care. The next thing we'll talk about is a very broad area, which is the mutation-driven metastatic non-small cell lung cancer. Again, I apologize that I won't be able to cover every single mutation, but just looking at this table, you get a sense of these are all the mutations that have FDA approved therapy, which means I can get the insurance and the payers to pay for therapy, at least in the US, for some of these different mutations. So I need all of these mutations tested on my patients, definitely the ones with adenocarcinoma, but often also the ones that have squamous cell carcinoma. So the ones that are recommended by our national guideline panels are EGFR mutation, ALK translocation, ROS1, BRAF V600, the NTRK, RET, and MET exon 14 mutations. And they all have some kind of targeted therapies that are FDA approved. There are a lot more markers that are out there that have drugs available in clinical trials. So ideally, like I said, if you have the capacity and have the resources to do so, any patient with an advanced non-small cell lung cancer should really get a next-gen sequencing panel so that clinical trials is also an option for the patient if available. So talking a little bit about the EGFR sensitizing mutations. So this was the big trial that I wanted everybody to know, which is the Flora Trial, which established osimertinib as the standard of care for tumors that are driven by EGFR sensitizing mutations. Essentially, from what you can see, these are the progression-free survival and overall survival curves, which are very impressive. And there is no other TKI in this realm that does a job as good as this medication. So osimertinib has established itself as sort of the primary drug that we use for anybody with stage 4 EGFR-driven adenocarcinoma. The side effect profile, like you can see, again, it's fairly tolerable. If any of you have used this medicine, you know it's fairly tolerable compared to some of the other TKIs. I do occasionally see patients have decreased ejection fraction, so having good cardiac monitoring is important. And, regardless of how we grade, having grade 1 or grade 2 diarrhea for the next 3 years of your life, it's not easy. Even though it's not a lot of diarrhea, it's pretty disrupting. So these are conversations that we should be having with our patients. It might look like it's not a very toxic drug on, based on clinical trial data, but anyone who has to take it every day, it's important that we talk to them and see how they feel about these side effects. Once people are on osimertinib or on any of the EGFR TKI, there often develops a clone that gets resistant to the medication they're on. And so these patients often can have slow progressions that are local in certain areas, or they can just have global progression, which is essentially everywhere in the body the disease is progressing. If they have local progressions, there are some schools of thought that say that, instead of taking away the osimertinib, you keep them on the medicine, but you try and use targeted therapies to take care of the small lesions that they have. So if they have like a solitary lung mat, a brain mat, you can use radiation if that's available as an option to take care of that and still keep them on the medication. And that way you can, have a sort of a longer time that they can stay on this. Some of the other, if they have global progression though, then that is sort of a gray area of, do you keep the osimertinib on or not at that point? But really, when someone has global progression, one of the things you want to look for in this subset of patients is for a small cell transformation, a MET amplification, a T790 mutation if they were not on osimertinib before, and then there are some other pathways. So if there is an option to do a rebiopsy or to do a liquid biopsy at progression, then that is something that's recommended. So what would you do for these patients on progression? So we kind of talked about it. You want to see if they have something else that's now driving their tumor. But I think that, there's a lot of controversy on it. There's a lot of discussion back and forth in the guideline panels, on social media. But I think the right answer is a clinical trial if that's available. Now, if that's not available, one of the safe options in this situation for these patients is to be able to use chemotherapy. Just the standardized platinum doublet chemotherapy is always a backup option for these patients. I would caution, and again, this is an area that is actively being investigated, is someone who has an EGFR mutation. I would be very careful about giving them checkpoint inhibitors after that, because there have been studies, and there are small studies, that have looked at patients who have gotten checkpoint inhibitors and have then gotten the EGFR TKIs, and they have been signaled that these patients have had much more severe adverse events. And again, that is not clear if that would happen if they got a checkpoint inhibitor after a TKI. So how you sequence the medicine probably makes a difference. But I think there is enough concern there that without a large clinical trial or enough safety data, I would feel very uncomfortable, and this is a personal opinion, I would feel very uncomfortable giving these patients checkpoint inhibitors till there is more data out there. I think chemotherapy with or without bevacizumab is a fairly decent option in these patients. And if I can get them on a clinical trial, that's what I would try to do. ALK rearrangement. This is, again, the next common mutation that you would find. Again, the big trial that they list that we talk about is the ALEX trial. This established alectinib as sort of the standard of care, at least in the US, for patients who have ALK translocation-driven non-small cell lung cancer. Again, a fairly tolerable drug. Against the progression-free survival benefit, 34 months. I mean, these are numbers that were unheard of in lung cancer 10 to 15 years ago. Patients just doing so well on oral medication. So it's just something to kind of wrap your head around. And then the overall survival, which we haven't even reached it yet, which means these patients are doing really well. I think something that's impressive both about osimertinib and alectinib is the fact that they do really well for patients who have brain metastases, and for patients who did not have brain metastases to begin with, there is a clear evidence that it delays progression in the CNS, which is why there's a lot of debate back and forth amongst experts about when they have progression in the rest of the body and if their brain, do you keep these medicines on just for CNS progression? We don't know the answer yet. Again, these are some clinical trials that will need to get more data on it. Once you have progressed on alectinib or brigatinib, the next TKI you have available for these patients, as you can see on this heat map, is lorlatinib. They can have all of these different point mutations, and lorlatinib in green at the end is probably the medicine that works against most of them in concentrations that we can safely give to patients. So that is sort of the accepted next line of treatment in patients once they have progressed on alectinib. And this was the study that looked at it. Again, one of the side effects, and I point a lot towards the side effects because some of these spaces have so many medicines in them. So you have so many TKI options for ALK, so many TKI options for EGFR. And sometimes it just comes down to the side effect profile. Is what is it that your patients can take based on their coexisting conditions? Something here, and I have seen a couple of patients have that, is hypercholesterolemia. It's not something that you think about. High cholesterol is not something that an oncologist checks for or looks for unless you really understand the side effect profile of these medications. So this is sort of the list of drugs that led to approvals in this space. Crizotinib has been around for a while. Alectinib, brigatinib is a good option. Just something that a clinical pearl about brigatinib is when you start patients on brigatinib, they have this very, it's sort of unexplained ILD-like disease early on. So you start them on brigatinib and they start having this sort of worsening infiltrates, a cough, and it just gets better on its own. So if they stay on it, it tends to get better. But again, something that I worry about, my patient population, a lot of them have pre-existing COPD and have respiratory issues. So I feel very uncomfortable using brigatinib in those patients. So my sort of first go-to is alectinib unless there's a reason they can't take it. All right, so sort of, again, there are these other mutations and there are multiple other trials that led to the approval of those medicines. But I think we'll shift gear and talk about sort of now the next big sort of bucket of patients in this, which is non-mutation driven non-small cell lung cancer. So the big trial here, which is something that all of us treating lung cancer should know about, is the KEYNOTE-24. This was the first trial that established pembrolizumab, which is a checkpoint inhibitor, as a standard of care, as an option that was acceptable for patients who had PD-L1 TPS score of more than 50% to be used as a single agent. Again, here are the overall survival curves, clearly a separation. And so that is an option for our patients who are frail, who have a high PD-L1 score. You can definitely use single agent pembrolizumab. It was sort of fairly established till KEYNOTE-189 came along. I was using it for anybody with a PD-L1 over 50, but KEYNOTE-189 combined pembrolizumab with chemotherapy, so platinum-based chemotherapy using pemetrexed in the patients with adenocarcinoma. So again, this is the studies, the way they were randomized is you use pembrolizumab and the platinum chemotherapy for 4 or 5 cycles, and then you maintain them on pembrolizumab alone or pembrolizumab with pemetrexed based on how they can tolerate that. And the data from here is very, very impressive. So much more impressive than the previous KEYNOTE study. So this is something that I sort of go to as default for my patients who have non-small cell lung cancer, adenocarcinoma, and can take chemotherapy. If they have symptoms, I definitely try and give them the 4 cycles of chemotherapy, at least a few cycles of chemotherapy, because I feel like you can get a better debulking and relief from symptoms when you use chemo up front, and the immunotherapy sort of takes care of the issues at the back end. Similarly, similar design, and this is for squamous non-small cell lung cancer, and you used Abraxane or paclitaxel in these patients instead of pemetrexed, which is used in the adenocarcinoma arm, again has established itself as a standard of care in this patient subset. I tend to use this a lot as well, even in the PD-L1 more than 50% population. Some of the other studies, again, this is a very, very busy space, is the Empower 150. I bring this up because they are using quadruple therapy with a taxane. Bevacizumab is on there. The only reason this study is notable is because they had a subset of patients that were that had an EGFR mutation. So we kind of talked about how we don't want to use immunotherapy because of a high risk of, or at least a concern for toxicity. But this was a study that enrolled patients with EGFR mutation. Again, the numbers were very small. It was a post hoc analysis, so not a lot of data, but is the only data we have. And these patients tend to do well, and is something that needs to be studied. So if you have a patient who has progressed on the standard TKIs with an EGFR mutation, and you want to give them more than just chemotherapy, then Empower 150 is probably a regimen that you could consider, adding the bevacizumab and the atezo. But again, the data is not high-level data, but it's the only data we have. Some of the other studies that were presented at ASCO this year was the Checkmate 227. Again, the curves looked impressive using dual checkpoint inhibition. And then this study using the Durva-Tremi was a negative study. So, this dual checkpoint inhibition with chemotherapy really did not pan out. And then the Checkmate 9LA, which again used dual checkpoint inhibition, but with chemotherapy for 2 cycles. So clearly, too many regimens and too many options for patients with non-mutation driven non-small cell lung cancer. So how do you pick a regimen for your patient? So the way I look at it is if all things are, being equal, if they are all equally efficacious regimens, then the things that I start looking for is the toxicity profile. if I can give someone the same benefit of progression-free survival and overall survival with 2 drugs, why would I give them 4? Because, you know, the more drugs you add, the more toxicities you add to the patients. And something that not everybody looks at, but is something that I feel very strongly about is look at the study, look at the demographic table on the papers that led to the approval of these drugs. Does the demographic table match the patient population in your clinic? If you have you know, all healthy, you know, relatively healthy white males with the ECOG of 0 and 1 on the study, that might not be your patient in clinic. So, you know, maybe they did well on those 4 drugs, but you have an ECOG2 patient who has multiple other comorbid conditions. So really trying to extrapolate what you saw on the study to your real patient, often it doesn't add up, which is why there's a strong push in the clinical trials community that we need to be including patients who are ECOG2, patients who have other comorbid conditions, patients who are older and frail on clinical trials, so that the data that we generate is reflective of the real world. So, you know, sometimes, you know, these 4 or 5 drug regimens, I don't think I can use that in my patient population. So I think that factors significantly into my decision making of what I would pick. There's also availability and cost. You know, depending on which part of the world you are in, are some of these drugs available? Are they available in a cost-effective manner? I think is important. You know, I am lucky that I have access to most drugs in the US, but I grew up in India, and I know most of the world does not have access to the same drugs. So really you have to pick what's the best available from whatever options you have. Again, when you treat stage 4 disease, you're treating a whole person. So it's not just about the tumor that you're trying to shrink or not shrink or make it go away. You're treating the entire person, and for a lot of patients at that point in their life, quality of life is an important metric. So if you have a drug that prolongs survival by 2 months or 2 weeks or 3 weeks, you know, it might be important to certain people, but so it's certainly not, nobody wants to take a drug that makes them live 2 months, but that 2 months will be spent in the hospital because of side effects. So again, when you look at papers and new approvals, keep that in the back of the mind, back of your mind is this also improving my patient's quality of life? And if this was a drug that I had to take, would I feel comfortable taking it? And then I am a big believer of shared decision making. So use your the data you have and present all the options to your patients, you know, the pros and cons. And then, you know, this is a decision that y'all make together. So the patient is an equal part, and probably is more important than you in this decision making, because they're the ones who actually have to take the drug. So my current algorithm for treating non-mutation driven metastatic non-small cell lung cancer is definitely I want to make sure that they get all the basic mutational panel. Ideally, I would like to get an NGS panel on all advanced tumors, but I understand that that's challenging in some places and not always possible. If their PD-L1 is more than 50%, I can give them pembro monotherapy, provided they are sort of older, frail, they don't want to take chemotherapy, or they don't have a lot of symptoms, have very little disease burden. I am comfortable giving them pembrolizumab monotherapy. But I always, you know, barring that, I always offer them the chemotherapy and immunotherapy combination. If PD-L1 is less than 50%, then I am always giving them chemoimmunotherapy as much as possible. You know, there are certain frail patients who cannot tolerate that, and I do end up taking away the chemotherapy. So I'll follow the Keynote 189 and the Keynote 407 studies for the squamous and adeno patients. The last thing that I wanted to kind of touch a little bit is sort of the whole Pandora's box of immunotherapy related side effects. So this is just something that we're learning about. You know, a lot of these regimens, like we saw Checkmate 227 and all these regimens with dual immunotherapy, the way they are marketed to patients is we're offering you a chemotherapy-free option. So patients automatically start thinking, okay, there's no chemotherapy, so this might be a much safer option. It might be better for me. which it's true in some ways. So you don't, don't start losing your hair, you're not throwing up, your blood counts are not down, which I know is very distressing to a lot of patients and is a big part of their decision making. But they come with a whole set of side effects that are very new, very different, not very expected, are not temporally related, so can happen at any point, and are something can be often devastating for patients and something that could be a lifelong complication. So I think we should probably think a little bit more about that and see how we address that in our individual practices. So the way I see is, again, if I'm trying to explain this to the patient, how does immunotherapy work? So when I infuse immunotherapy to the patient, it's not the immunotherapy that's going and killing the cancer. The cancer cells have this cloak of invisibility, or the tumor has this cloak around it like Harry Potter that makes it invisible to our immune system. And what these immunotherapy, the checkpoint inhibitor drugs do is they go in and they take that cloak off, and now the cancer is just white and visible to the immune system. And then the hope is that the immune system is going to attack the cancer and then take care of the cancer and make sure it doesn't grow anymore. I'm not sure, and that's where sort of the problem happens, is sometimes the immune system can go a little bit rogue and start attacking more than just the cancer cells. So when we really run into trouble is when it's attacking the cancer cells, but it's also attacking healthy tissue around it. That's when you have all these sort of widespread side effects from immunotherapy. So we'll just kind of go through a case scenario here. So a 70-year-old man with metastatic lung adenocarcinoma, had a PD-L1 of 70%, had no driver mutations. He was a little frail, did not want to do chemotherapy, so we started him with single agent pembrolizumab. He was really doing well. He had a lot of disease reduction on his restaging scans. And then started to have, over a weekend, started to have some diarrhea, some joint pain, and went to the local ER. And he probably went there and told the local ER, I have cancer, I take chemotherapy, which is really not chemotherapy, but that's what he said. And the sort of mindset instantly is, somebody on chemotherapy probably has low counts. We'll check them for a sort of C. difficile toxin, for some GI bug. All of that was negative, and the patient was sent back home. So after the weekend, on a Monday morning, the patient then calls the oncologist's office and says, I have this diarrhea, it won't stop, I can't keep anything down, and they are immediately seen in the clinic. So this is sort of the recognition and the education that a lot of our providers, who are frontline providers who take care of patients with cancer, need, is this patient is not on chemotherapy, they were on immunotherapy. So the side effects that they have are a little bit different than what you would expect with chemotherapy. So what did he have? So essentially what our clinic nurse would do is she would grade their diarrhea and ask them for symptoms. And this is still in evolution, immunotherapy related colitis and immunotherapy related side effects. How do you grade them? I think we're still looking at different ways to do it more adequately than just the way we do it for chemotherapy. But essentially, this person ended up getting admitted, getting high-dose steroids, getting a endoscopy done, and essentially had lymphocytic colitis from his immune checkpoint inhibitor, to the point that he could not get back on pembrolizumab after that. So this was potentially a near miss. This was potentially a life-threatening complication that could have been missed had he not called the clinic, on Monday morning. So ASCO and a lot of the other guideline bodies have guidelines on what to do. So any kind of grade 1 toxicity, you hold the medication, you monitor for dehydration, you just kind of keep in touch with the patient, the caregiver, and if this is persistent and will not stop, you really want to call your gastroenterology colleagues and see if an endoscopy is warranted in this situation. If they have grade 2 diarrhea, again, you want to hold the medication, make sure the symptoms recover to grade 1 or less, and consider starting them on high-dose steroids. Again, grade 3, you're discontinuing the medicine permanently. Again, it's a little bit of a back and forth whether you want to restart it or not, but really the general consensus is if it was severe enough, you might not be able to re-challenge them, especially with the CTLA-4 drugs. And then the dose of steroids is something that I want everybody to pay attention to. It's not those low dose steroids that you give for a COPD exacerbation. These are 1 mg per kg or 2 mg per kg high dose steroids that you administer for these patients. Preferably you admit them to the hospital, you give them IV hydration, and start them on these high dose steroids, and you keep it on for a really long time. You do not de-escalate it quickly. Sometimes it might take up to 4 to 6 months before you can wean them off their steroids. So there are some patients, the moment you start tapering the steroids, the diarrhea is back on, the pneumonitis is back on. So again, not the small course of steroids. You want to give them large doses of steroids if you suspect an immune checkpoint inhibitor related toxicity. So our patient essentially got the steroids, but also needed infliximab. So it was that severe. At this point, the patient is in complete remission, has some mild arthralgia, is on low dose prednisone, but never got back on pembrolizumab after that. So again, immune-mediated colitis, it's about 2 to 3% incidence. Patients can have blood in their stools, diarrhea, abdominal pain, just all the common things that you see with this kind of Crohn's or UC kind of disease. So immune-related adverse events, it can happen essentially from head to toe. Any part of your body that can get inflamed can get inflamed. Most of them are mild to moderate, which is reassuring, which means a lot of our patients, you have to hold the doses temporarily, maybe treat them with steroids for a little bit, but you can get them started back on the checkpoint inhibition. But in some patients, this can be pretty devastating and can also lead to death. So some of those big ones that you do not want to miss are pneumonitis, and myocarditis, hypophysitis. Myocarditis especially, it's so rare that it happens, but when it happens, it can often lead to an ICU admission, it can lead to death. So again, some of these things that not just the oncologist needs to know about, but all the other physicians, all the other team members, the nurses, whoever else touches these patients, their primary care providers, they all need a little bit of education to understand that these patients are not like your regular patients of chemotherapy. They are coming in and they have these whole different set of side effects that if you don't look for it, you will not find it and can often be devastating. So again, essentially anything from anemia, myocarditis, blepharitis, nephritis, encephalitis, and I have seen pretty much the whole spectrum of this in my practice, and I exclusively see lung cancer patients, but if you treat enough patients on immunotherapy, at some point you will see this. A clinical pearl here is, and you could have gotten that immune checkpoint inhibitor 8 months ago, and you might not be on it anymore, but you are still at a risk for an immune-related adverse event. So something to remember, they might not be actively taking the medicine now, but if they have gotten it at some point in the course of therapy, they are still at risk for side effects. So again, this whole team-based approach in cancer care, I cannot emphasize that enough. All the way from diagnosis to management of side effects, you need your entire team on board. Everybody, not just the oncologist, but everybody on the team needs to understand what are the things that are high risk and how do you manage that. So some of the strategies that and the patient is part of that team. So you could have all the knowledge in the world, but if the patient does not know what are these side effects that they need to look out for, then often they will come in late and you might not be able to help them out. So some of the things that places here do is we provide our patients with immunotherapy cards. So essentially, if they end up in an ER or in an urgent care center that is different from the hospital they're being treated, they can show that card that says, I am on immunotherapy. It's like a medical alert bracelet. And that will sort of set off the red flags. Okay, we need to call their oncologist and find out what's going on. And then when patients come in, and if they're sitting in a waiting room to be seen, something that can be easily done is give them a handout so they can check off the side effects. So, they can check off this whole list, because it's very hard to ask these questions in a 20-minute or 10-minute clinic visit. But while they wait for you, they can easily fill out this questionnaire. And that will sort of give you an idea of what kind of side effects they're having. Again, we kind of went through this grade 1, grade 2, grade 3. Grade 3 and above, the recommendation is really be very careful about restarting the immunotherapy drug again. But that's all I had. Here's my slides, and thank you. Ready for any questions?
Thank you so much for your excellent presentation, Dr. Doss. We really do appreciate your time to come out here today. And we also wanted to congratulate you on your excellent presentation. So thank you very, very much. Before we do get into the questions that everyone can feel free to ask questions in the chat for Dr. Doss. Before we get into that, we have the Cameroon chapter, which would like to do some live questions. Yeah. So feel free, Alfred, to unmute yourself and ask Dr. Doss any questions if you have any.
Good afternoon. I'm Dr. Kuya Francine. I'm in charge of the oncology program in Bingo. Thank you for this excellent presentation. So I think that I don't know if maybe you are aware of the context in which we are working in Bingo Baptist Hospital. I would have loved to see the recommendation of lower middle income countries. And I know that more and more that is what is happening because, probably over there, there's a health insurance, people don't pay out of pocket. Mm-hmm. Here, the majority of the patients, almost everybody pay out of pocket. Yes. People have to sell their property to pay for the medication. This is simple chemotherapy. Right. So this immunotherapy, I'm not sure it is for now here in Africa. First, we don't do the mutation. Mm-hmm. If you have to do those mutations, you have to send a sample maybe abroad. Wow. And the majority of our cases, the non-small cell lung cancer, they are coming maybe at stage 4. You see, they are so sick. We are running after time. Usually, we have to choose what do we do. Should we exhaust the resources of this family for somebody that we don't guarantee the survival? So usually, we have first to discuss with the family, how far do you want us to go? If the family say that we are able, there are people who are able to pay, so it's okay, we can go far. But if the family say that we don't have anything, truly, we just do simple palliation. So usually we use chemotherapy.
Uh-oh, did we lose them?
Okay.
Yeah.
So we use chemotherapy. Even with chemotherapy, for example, when we use a platinum-based protocol. Yep. With cisplatin, it is possible to treat to get it, but when you prescribe carboplatin, it's almost impossible because it's expensive and people are not able to get it. Another important thing that here with the immunotherapy, you look at the side effects. People are living in remote area. Mm-hmm. The coverage of how they call it? The coverage of the network. Sorry, the network usually in those remote areas you will not have the coverage. So if you have such patients in lower middle income countries, how do you handle them? Because it will be impossible for them to get you. I want to just take the example of high-dose methotrexate that we use here for tuberculosis lymphoma. If I give high-dose methotrexate to a patient, that patient is not leaving the hospital until I make sure that he's out of maybe he's out of danger. I make sure that he doesn't have mucositis. Because if he gets mucositis in the village, and those are drugs that other people don't handle, and then you may lose that patient. So I just imagine with all the side effects, with the with this immunotherapy, how in a lower middle income country it will be possible. So my suggestion is that probably the best way for us is to have they call it the recommendation of lower middle income countries, so that it will really fit into our setting.
this is such great feedback. I don't know if you knew that I am also a member of ASCO's International Quality Task Force, and a lot of our work as a part of that committee is to help come up with ways for low and middle income countries. How do we help? How do we learn from experiences of different countries? How are the ways to make some of this accessible, and kind of coming up with good quality measures that are applicable to your individual setting. So I think you made a great point. I am happy to share my email ID with you, sort of offline. And you should come and speak you should speak to our committee. I don't know if you're an ASCO member, but this is something that we have been actively working on. We have a lot of different countries that are on there. I understand this because, my parents live in India. I grew up in India. I know the challenge of having to go and buy chemotherapy before it's administered. If you don't have the money, they don't get it. So the point you make are excellent. And these are points that everybody needs to understand. And sort of there needs to be a global sort of initiative in how do we make sure the standard of care is applicable to the individual country's resources. So you make a great point. I would love to connect with you more if that's something you're interested in, so we can kind of brainstorm on this some more.
And also the other thing that I am thinking is that maybe if we see those patients with the early disease, I think that's money that we can use less money to maybe to screen patients and
Yes.
see them at an early stage than to have patients with advanced disease.
Yes.
And then we say, okay, let's think about immunotherapy. It will be a dream in Africa. It will be a dream. So I think that's what we need is to screen patients. Method on how to screen patients, maybe high risk patients, screen them. Then that is the best way to do that.
I completely agree. It was so refreshing to hear that perspective. Thank you so much.
Okay. Thank you.
If there's any other questions, you can either ask right now in the chat, and if not, you can always send an email to Dr. Doss. Again, Dr. Doss, we want to thank you for your excellent presentation, and we look forward to the next presentation with us. Thank you, everyone.
Thank you, Ellie. Feel free to share my email with anyone who has questions. I would love to connect and get feedback.
Okay, sounds good. Thank you. Bye, everyone. Thank you for coming.
Bye.